Good evening, everyone. We'll give it a minute or two more while we wait to see who else shows up here. And then we'll get started. And my guess is we'll have a few more join us as we go. Welcome to the third episode of Focal Point, presented by Aniridia North America. My name is Janelle Collins, and I'm your host for tonight. I live in Florida, and I serve as one of the board directors for Aniridia North America. My awesome 15-year-old daughter has aniridia, so that's how I'm connected to the community. Our episode tonight is focused on Aniridia 101, how to care for a child's eyes with aniridia. And our guest for tonight is Dr. Alex Levin. I am going to read his bio here just because memorizing it, it's quite complex. So I'm going to go ahead and read. Dr. Levin holds the Adeline Lutz Stephen S.T. Ching, MD, Distinguished Professorship in Ophthalmology as the Chief of Pediatric Ophthalmology and Ocular Genetics at the Pflaum Eye Institute and Chief of Clinical Genetics at the University of Rochester Medical Center in New York, where he is a professor of ophthalmology and pediatrics. He attended Jefferson Medical College in Philadelphia and then completed a pediatric residency at Children's Hospital of Philadelphia, and then completed the ophthalmology residency at Wills Eye Hospital in Philadelphia, followed by a pediatric ophthalmology fellowship at the Hospital for Sick Children in Toronto, where he continued as a staff ophthalmologist and professor in the Department of Pediatrics, Genetics and Ophthalmology and Vision Science at the University of Toronto for over 16 years. There he founded the Pediatric Glaucoma and Cataract Family Association and continues as chair of their scientific advisory board. In 2008, he relocated back to Wills Eye and recently moved to his current post in Rochester. He holds the unique U.S. board certification combination in pediatrics, ophthalmology, and child abuse pediatrics. He has published or has impressed 308 papers, 162 chapters, and 13 books. He has delivered over 1,530 presentations worldwide. He has a long-standing interest in pediatric glaucoma and cataract. Caring for children with aniridia and Weger syndrome has always been a central core of his practice. He founded the Robinson Harley, MD, CGRN International Pediatric Glaucoma Registry, which currently has over 900 patients enrolled from 5 continents. On a more personal note, since I have not actually seen Dr. Levin as a patient, I asked someone who has to tell us about him. And Casey and Molly Harshman said Dr. Alex Levin is and has been the foundation for the ongoing care of our daughter, Lois. He performed Lois's first set of eye surgeries when she was only 9 weeks old. And to this day, we have full access to Dr. Levin as he has helped us navigate a very challenging road for Lois. We are so fortunate that we found Dr. Levin and have been amazed at the care he has provided to Lois and to us as parents. And we've witnessed firsthand the countless other families that he supports in the very same way. We are eternally grateful for his incredible skill and wisdom, along with his willingness to share this with others around the world. Given all that, I'm so honored to have Dr. Levin join us here tonight. Dr. Levin, thank you so much for being willing to take the time.
Thanks for having me. It's a pleasure.
We are tonight simply going to go straight to questions. We had so many great questions sent to us that we figured that would be the best use of our time. So thank you to everybody that submitted them already during registration. If you think of more questions as we talk, feel free to submit them through the chat. We will try to monitor all of that and do as much as we can with the chat as we go. So let's get started without further ado with our questions. Dr. Levin, I had somebody, Jennifer in Florida, said, we don't understand how our daughter is legally blind when she seems to be able to see. Can you explain that to us?
Certainly. First of all, many thanks again for having me. It's great to be here, and I welcome any questions from anyone, anytime. There is a line in the sand that was drawn many, many years ago that said that 20/20 would be normal eyesight. That means there's a certain size letter that you can see from 20 feet away. That same person or people could have decided we would be 20/40 would be normal. And if they decided that, our stop signs would be twice the size, a newspaper would be twice as big. 20/20 is what we consider normal based on the average vision of people. And as it turns out, some people see less. And at some point in time, As you go down from 20/40, which means you have to stand at 40 feet to see what a normal person sees at 20 feet, to 2200, where you have to stand at 20 feet to see what a normal person can see from 200 feet. Legally, this line was drawn in the sand that said above, worse than that, you're legally blind. You can still see fine at 2200, but that's where the benefits kick in, tax benefits, low vision services, and all that is at this line in the sand. Um, People who can see 2020 are very blurry. They can barely see the big E on the chart when they're sitting in a doctor's chair, but they can still see. As you are younger, as a child, 2200 is fine. In fact, babies are born with about 2200 vision. And if you go to my waiting room and you look at 1, 2, 3, 4 year olds, you can't tell the difference between a normal kid and a 2200 kid because their need to see is less. How much does a 6-month-old have to see? Need to see his mom's face, dad's face, a bottle. That's it. So until you're ready to sit at a blackboard in the back of a classroom and read math equations, that's where the pedal hits the metal, right? That's where you have trouble distinguishing as your visual tasks get
Right.
more and more. So at 2200, you can see, and you can see like any other little kid, but you're still legally blind, meaning you're beyond that threshold, that legal threshold for blindness.
That was a fantastic explanation for that. Along those lines, you mentioned that babies typically are born with like 2200 vision. We have noticed that babies with aniridia often have their vision kind of wake up a little later than other babies, often somewhere between 3 and 8 months. And until then, it seems like they don't see anything. Can you tell us like why you think that might happen or tell us about that?
A lot of that is a bit of a trick because babies with aniridia often have nystagmus. And when the eye is shaking back and forth, it looks like the baby's not fixated. The baby's not looking in one position. And in fact, they are. And that eye movement, they don't see the world move. If you throw a ball into the air and watch it come back down to your hand, at the very top of that movement where it changes direction, it's actually not moving at all for a split second. And what the baby is doing is sampling from one end to the other end. At each stop of change of direction, it samples that and puts it together like a movie theater, like a movie, right? It's blurry, but it creates a still image. As babies get older, no matter what the cause, shaky eyes, nystagmus gets less and less and less. It rarely goes away completely, but it gets less and less. And therefore, as the shaking is less and less, it's more easy to notice that the baby is actually fixating and looking at you. So it's not a wake up period. It's not a change in the brain's ability to see. It's in really the parent's ability to notice that the kid is looking at them as their eye stops shaking as much. There's no magic to 3 months to 8 months. It just gets better as they get older.
That makes a lot of sense. All right, so given that, how old does a child have to be before you get a good idea of, kind of what their visual acuity is?
Yeah, that's really hard because when a child is able to read a chart, you can quantify their vision with whatever number or letter or picture they can see. Before then, our methods of determining a baby's vision are much softer. We do have methods for getting a number at a younger age, but they're not that good. They're not that accurate. And really, we have to wait until a baby is able to clearly name shapes or pictures or whatever on a visual acuity chart. And over time, indeed, that'll become apparent. We can't look at a baby very well and tell, oh, this baby's going to see that vision later on. That we can't do. We have to wait until the child can give us the feedback of what they actually see.
That makes sense. You just explained actually how the numbers for visual acuity work, so we can skip over that question that I had. So let's move on to appointments. How often, if you have a baby who's just been diagnosed, how often do you want to see that baby in that first year or two of life?
So we consider the follow-up based on the milestones that can occur in a normal developing child, along with the things we're screening for in aniridia. So if a baby is born with aniridia and has a fairly normal appearing eye, except for the iris, we're looking for glaucoma, we're looking for cataract, and we're looking for the cornea to be involved. Those are our three main progressive concerns. Other things like the retina being born underdeveloped, that's stagnant. That doesn't change much over time. So when I see a baby, I'm thinking, when do I really have to know if these things are present? We take out cataracts at 4 to 6 weeks of age. That's our general rule of thumb when a visually significant cataract. So I want to see a baby at 4 to 6 weeks of age or a little bit earlier if possible, to know that's not there. Glaucoma, I usually like to see them before 4 to 6 weeks of age. If I know a baby has aniridia, I'll see them as soon as I can. But then 4 to 6 weeks of age, I'll usually see them at 3 months, at 6 months, and then I follow them every 6 months thereafter, both for the development of cataracts, cornea problem, and for glaucoma.
That makes sense.
And I should add, there's really no free zone. You don't hit a certain age and then, get out of jail for free card. You've always got the problem and you always need the ongoing screening over time.
Yeah, really 6 months is every
That's what I do.
for lifetime, really, probably.
Yes.
Unless something comes up that's an issue.
Mhm.
Okay, so Sherry from Maryland asked, what is the most important thing a parent can do to preserve their child's vision?
Regular eye examination is important. You should be under the care of a doctor who's familiar with aniridia. If your doctor says, I've only seen one kid before, you probably want to find someone else. Number two, if you notice a change, you want to be in the care of a physician who's going to respond to your call. We know that's unfortunately not always the case. You want to be able to pick up the phone and say, hey, I noticed this change. What's going on? The other things that are important, I think, for kids who have glaucoma, kids who have aniridia, is artificial teardrops. There is some evidence that using artificial teardrops available over the counter, preservative free is preferred. There's many different brands. On a regular basis, I tell my patients with aniridia 3 or 4 times a day that helps lubricate the surface of the eye, the cornea, which is prone to degenerate or have certain kinds of changes, scarring and blood vessel growth over time. And there is some evidence that keeping well lubricated eye can help prevent the cornea problem that can occur in this disease. It's not a foolproof shield. It's not a bulletproof shield, but it's one thing you can to promote your child's eye health. So regular eye exams by someone who knows what they're doing, artificial tears would be what I would recommend.
Okay, excellent. You mentioned there are a number of different brands. Are there any specific ones that you like better than others, other than the fact that they need to be preservative free?
You could ask 10 ophthalmologists to get 10 different brand names. I'm not sure that there's a lot of evidence that one is the superior brand. In my practice, I have no financial interest. I happen to like Refresh, but there's all different. As long as they're preservative free, it's fine.
Okay. Somebody with aniridia, an adult with aniridia, Joy just mentioned, she's noticed many of the wetting drops actually seem to dry out her eyes and almost feel like sand in the eye.
So we should, first of all, differentiate between wetting drops and artificial tears. Wetting drops are compounds for contact lens wearers, but artificial tears are different and they shouldn't make you feel dried out per se. I wouldn't use a wetting drop in your eye if you're not a contact lens wearer.
Okay. All right.
And someone just wrote in the chat, Refresh is one that I can't stand.
Yeah.
And that
So
goes to show you, there's all this
person.
Different people like different kinds for various reasons. Some are more viscous than other. They're thicker. People don't like that. Some people don't like the more thin ones because they come out of the bottle too fast. Some people have brands that sting and they don't sting other people. You can go and experiment with whatever you want. I'd say as long as they're preservative free, use the one you like the best.
Okay, that makes sense. Speaking of which, Are there any natural ways that as a parent, apart from eye drops, that we can keep the eyes healthy, whether it's lifestyle or food or anything like that?
That's a good question. There are no herbal substitutes or um, additives that we know are helpful. We know that a well-balanced diet is good for everyone,
Right?
and that's recommended, although it's sometimes hard to get your kids to eat a well-balanced diet.
That's the truth.
But I think that there's really nothing that you can do in particular. Wearing sunglasses is helpful. It cuts down the rays of the ultraviolet rays of the sun, which have some contribution over time to decreased eye health, but that is kind of minimal, and it's not worth fighting over with your kid. You've got enough battles to fight. So that's one that I tell my parents, if you can get them to wear sunglasses, great. Not necessarily. If a child is having a lot of problems with bright lights are bothering them, then you can wear sunglasses to help relieve that symptom. But as a preventative treatment to make the child under the impression that you're trying to keep the child from seeing worse, I don't know that there's any evidence that that's really true.
Okay.
Short answer, no.
Okay. Another question, how do we get through the dry eye season without, especially fall to spring up north? Is there humidifiers? Would that be helpful? Anything like that? Any ideas?
Artificial teardrops are great. I mean, that's your natural, that's your replenishing your natural surface. I've never lived in a place that has a dry season. There are allergy seasons, and if a patient has allergy and allergic conjunctivitis, there are medicines you can take to help prevent those symptoms under the care of your doctor, not over the counter. But other than good lubrication, I don't know that there's any evidence that a humidifier is going to make a difference. If it does for your kid, certainly not harmful.
Okay, great. Sarah from Sweden asked, is it safe for Aniridia kids to play water sports?
Absolutely. I'm a big believer in letting kids be kids and let them do whatever. I don't restrict my kids with aniridia from any activity. If they're contact lens wearers, which some patients with aniridia are, you shouldn't swim with your contact lenses in. But other than that, go for it. Have fun and enjoy life.
Wonderful. So then a chlorinated pool is safe for our kids? Or
Yes.
should goggles be required to protect the cornea?
I don't think there's any evidence that goggles are necessary.
Okay.
I see there's another expert on the call, Dr. Netlin. Maybe he has another feeling about that, but I don't recommend goggles unless the child has a problem,
Right.
transplant or something like that, that you're trying to specifically protect.
Yeah, if they've already got a significant corneal issue or something like that, then it would make sense. Okay. Somebody actually in the chat just asked, can we go swimming with a bandage lens?
Yeah, if you're wearing a bandage lens, there's a reason for that. You're bandaging something. There's some underlying problem, and in that situation, you should discuss with your doctor what that problem is and whether or not you need to take special precautions. In general, you want to stay out of the water when you got a contact lens of any kind in your eye.
Okay.
In particular, fresh water.
Oh, yeah, that makes sense. That makes sense. Justin from Colorado in the chat mentioned my daughter's scheduled for a shop class in middle school. How big of a concern is airborne dust particles and flying debris despite safety glasses? Teacher says 6 out of 100 kids go to the office per year with foreign matter in their eyes.
Yeah, that's an interesting teacher. So, there is foreign matter everywhere you go. Everywhere you walk outside, there's foreign matter in the air. And you can get foreign matter in your eye anytime. In a shop class, you're increasing the chance. You got sawdust flying around, so on and so forth. You wear goggles, and appropriate safety eye protection is there to protect your eyes. I don't think there's any reason to limit a kid with aniridia. There's no way you're going to limit every single exposure. Again, I'm all in favor of doing whatever you want to do. And if you can cover the eyes and decrease your risk a little bit, that's good.
That makes sense. Speaking of extra eye protection, if playing other sports like contact sports, that kind of stuff, should there be extra eye protection for somebody with aniridia, or just play and have a good time?
I'm the father of two boys who played hockey in my yard, in my driveway. And I say to them, wear eye protection, would you? Hey, come on, wear a face mask. That's the way it's been well shown. When face masks became required in Canadian sports, that's where it became the first country to require them. And I'm from Canada. The incidence of eye injuries went like this and dropped precipitously from hockey. It was amazing. It was like overnight when it was legislated that every kid had to wear face protection. Could I get my kids to wear it? Never. So, other than the law, which says you can't play organized hockey in Canada without a face mask, it's hard to get kids to wear eye protection. Would I like every kid who's in a sport that has contact, a ball or a stick, to wear eye protection? Yes. Does a kid with aniridia have to take any additional special precaution? If they've had surgery, if they have a corneal transplant, yes. But are they going to do it? Good luck with that.
Right.
And it's hard. Most of these kids are in glasses anyway. As long as your glasses are made out of polycarbonate break-proof plastic, or for higher prescriptions, just plastic, that should serve as an adequate protection. But remember, kids don't want to look different. They don't want to look like who's the geeky kid who's wearing eye protection when no one else is. You got to have to take that into account as well. So
Yeah.
you can get it, go for it.
Yeah, so social things have to be taken into account. By the way, Dr. Netlin said the same thing as you. He agrees that no goggles is fine for swimming. So he thought the same thing as you. So Diana from Alabama mentioned, we know that aniridic eyes, the corneas, have a harder time healing when injured. If you have a toddler, what is your opinion on wearing glasses simply to prevent eye injuries if they don't need the prescription yet?
Again, good luck with that. I mean, kids wear glasses when they have an improvement in their quality of life that they can notice. They notice that they can see better, then they have an incentive, an inner incentive and drive to wear them. Without that, it's hard to get them to wear it. If I could, that'd be great. But then I see kids who get a ball hits their glasses, or glasses hit their eye and they get an injury. So, you have to do what's right for your kid. There's no right or wrong answer.
Okay, that's very helpful. Are there any sports or activities, and you've kind of already answered this, but if you have a child who maybe has already had a retinal detachment or who has significant increased IOP, so we've got a kid who does have some complications right now, are there any sports that then they should avoid?
I would say no. I tell my kids who have tubes in their eyes that they can do whatever. And I encourage eye protection to the best of their ability. Many of them need glasses anyway. No particular sports. Having a raised pressure needs treatment for the raised pressure,
Right.
but that in of itself doesn't prevent you from playing any sport.
Okay, excellent. And one that we've heard a couple of times, are roller coasters safe for our kids, or at least as safe as they would be for anybody?
Well, I'd add that roller coasters, playing a trumpet, trombone, lifting weights, those are brief elevations of your pressure. I think they're clinically insignificant. Would I want a kid to be playing her trumpet 8 hours a day? Probably not. But for those brief exposures, it's okay.
Okay, awesome. Let's talk a little bit more about glasses. We brought that up a little bit already, but prescription glasses. How do you as an ophthalmologist know when a little one, I'm talking baby, toddler, how do you know when they need prescription glasses? People always ask us this question.
Yeah, it's a good question, because you're used to going to the eye doctor and we do that annoying thing, better one, better two, and you figure out what your glasses are, right? Kids can't do that. All glasses do is bend light to fit the shape of your eye. That's all they do. It's just a trick, right? So if I know the length of your eye or the shape of your eye, then I know what your glasses prescription is. If you're nearsighted, you have a long eye. If you're farsighted, you have a short eye. If you have astigmatism, it means the front surface of your eye is not perfectly round. So I can take a light, shine, it's called a retinoscope, and I can hold up lenses in front of a baby's eyes until my light is essentially focused on that baby's retina inside their eye. And when I have that, I'm holding in my hand the amount of power that's needed to focus the light for that shape eye, and that's your glasses prescription.
That is fantastic. So along those lines, why wouldn't an Aniridia child need glasses? We have people ask, wait, shouldn't all of them need glasses?
You can buy the most expensive camera in the world, put on it the most expensive lens money can buy. But if you load that camera with bad film, you get bad pictures, right? So all the glasses in the world can't correct some of the problems inside the eye. If the film, say the retina, which is the film inside your eye, is underdeveloped, what we call macular or foveal hypoplasia that we see in aniridia, you can't fix that. You can get the best focus, but some kids have a normal shaped eye, and therefore the glasses can't make it any better. You can't make the film better in that situation.
Okay. So given that, if some people then ask, well, if my child's visually impaired, if they have the bad film, how can the glasses actually help them? And obviously that goes along with that shape of the eye situation, I'm assuming.
So if you have a bad film on the camera, you still want to focus it the best you can, right? And if your eye is a longer eye and you're a bit nearsighted, you can focus it, still get a blurry picture, but a less blurry picture with the extra focus.
Okay. Is there any age at which we should not be prescribing glasses, like infants or before a certain age, or does it just depend on the child?
No, it depends on the shape of your eye, and your age is important too. So say you're a baby and you're mildly nearsighted. That's a great thing to be mildly nearsighted, because babies live in a world that's very close to them, right? So they're automatically focused at near, and they don't care about the street sign half a mile down the road. So at certain ages, the right focus is normal. For me, right, I'm at an age where I need a little bit of help seeing up close. So everybody's age fits into the equation of when you need glasses.
That makes sense. If a baby were to get the wrong prescription, like for some reason it didn't get measured correctly, can that cause the eyes harm, or is it neutral?
It depends. If you wore my glasses prescription for the next 10 years, it wouldn't harm your vision at all.
Okay.
When a baby is still developing vision, the object is to get them as clear a picture as possible while they're developing vision, because that encourages ongoing visual development. If you have the wrong glasses prescription, they wore my glasses, that would blur their vision and would impair visual development. Normally, when you get glasses from the doctor and they're a little off or whatever, that doesn't make a great difference. But it could conceivably if you were way off on the glasses prescription, which doesn't happen very often.
But with a good ophthalmologist, that's not going to happen. So, right. Okay. You answered that. What do I do if my child absolutely refuses to wear his prescribed glasses?
So when a child refuses glasses, there are several distinct reasons. The first is, do they fit? If they hurt, they're not going to wear their glasses. Go back to the optical store and make sure they fit right. The second is that it's the wrong prescription and you're blurring their vision. That's unusual, but it's always a good idea to double check to make sure that is correct.
Sure.
The third reason is that the glasses are not sufficiently improving the quality of life for your child. In other words, their vision is not getting clear enough to make a difference in what they do. For a 6-month-old baby to go from 2200 to 2100 is insignificant. That doesn't improve their life. So it's one of those three things is at play. And one's check with the eyeglass store, one's check with your eye doctor, and the third is just an explanation that not going to wear them. Now, some kids are behaviorally adverse to wearing glasses. And what you do is you just keep trying and trying and try again and marry them with activities, positive reinforcement that may lead them. Like if they like video, you put a video on, you want to watch the video, wear your glasses today. And that can lead to positive outcomes. But one thing they shouldn't do is force the kid to wear glasses. You will lose that battle every single time.
Yeah, if they need to have buy-in, or else it won't work. Joy in the chat asked, should a 6-month to 1-year-old get them though, or should they be allowed to some time to develop on their own?
That's a myth. People are afraid of getting glasses too early, afraid my kid's going to get addicted and all that. They don't get addicted, just see better, and the kid likes seeing better. So if your doctor says you need the glasses, get them when you need it. There's no reason to hold off at all.
Okay, that's good to know. If the glasses are prescribed, but they don't materially improve their visual acuity, is it still worth having the kid wear them if they're willing to?
That gets back to the protective glasses, right?
Right.
If they're not changing your vision, it's like protection. And then the same answer would apply.
Okay, you addressed this a little bit already, but how important is it for Aniridia children to wear sunglasses? You said it's helpful for UV protection, right? But it's more almost for comfort.
So the truth is that regular glasses are over 90% as effective at blocking the UV light as sunglasses, as the most expensive $800 Varney sunglasses. So, how important is it? Not enough to pick a battle. So I would let that be excused in the background. That's my 5-year-old granddaughter who's singing songs. She loves to sing very loudly.
I love it.
And very poorly.
Well, that's we should sing with a joyful noise, right?
That's right.
And she's doing that. That's a beautiful thing. So in other words, what you're saying is, hey, if they'll wear them, that's great, the sunglasses, but we don't have to panic if they don't.
Correct.
That's fair. All right, let's move on to pink eye, that lovely thing that all of our kids have at some point in life, right? Grace from Oklahoma asked, my child seems to just have a lot of gunk or like stuff in her eyes all the time. Is that typical?
So the answer is no.
Okay.
All of us who walk around don't have gunk in our eyes all the time. Kids with aniridia are prone to getting not pink eye, but corneal problems. And when they get that, that's a very serious problem. Pink eye means that the white of the eye is a reddish or pinkish color from inflammation. And that should always be a warning sign in a kid with aniridia who's prone to these types of things, especially kids who've had surgery in particular tubes in their eye. You want to make sure that's not a harbinger of something bad that may be going on, whether it be infectious or irritation or otherwise. So I think that a pink eye in a kid who has aniridia should prompt a visit to your eye doctor, not to your pediatrician, someone who can take a look and make sure it's a benign cause. If it is just a viral conjunctivitis, which most of them are, that's fine. And the kid will recover and probably doesn't even need any medicine. But you want to make sure it's not something else. Another common cause of pink eye in kids is called blepharitis, when the 20 or 30 glands normally present in each eyelid don't flow well. And that can really aggravate cornea problems.
Sure.
So bottom line, pink eye, see your eye doctor.
Okay, awesome. Do we need to make sure that eye drops for pink eye, if it's bacterial, are preservative free? And does that even exist?
Some doctors are really, really strict with preservative free drops, whether it be glaucoma or antibiotic or whatever.
Okay.
I usually don't resort to that unless the kid is having a recalcitrant problem with continued eye irritation and I'm trying to wonder why, and I might switch up the drops. They're hard to find, they're expensive, they're often not covered by insurance, and therefore I try and reserve that card for when I really need to play it, which is the kid who's got bad ongoing cornea problems.
Okay, that makes sense. Are there any other things we should do to help the eye heal when my child has pink eye? Like if it's viral, is there any like cold compresses or something along those lines?
No, if you've got a viral conjunctivitis, you don't need treatment. If you got a bacterial, you may need antibiotics. If you got something else going on, you treat that problem. It's all problem directed.
Okay. So Micah from Arizona asked, what do I do if my child, especially a young child who maybe can't communicate with us, gets poked in the eye? You know, maybe a mild redness for a few minutes, but then the child acts fine. We're nervous about, corneal problems. How do we handle that?
Yeah, when in doubt, better safe than sorry. See your eye doctor. It's not going to hurt. Those visits can be priceless. I've had many a kid in that situation who's come in and needed something. A scratch of the cornea in you and I is very benign, and a kid with aniridia can last for a long, long time. It won't heal well. So when I'm concerned that a kid has eye trauma, pink eye, I welcome a call from a parent. They all have my phone number anyway. They can text me and come in and see me.
Okay. My son, Cassidy, asked, my son gets styes often. My husband and other son also have aniridia, but they never get them. Does this have to do with aniridias or just coincidence?
I'm not aware of any association between aniridia and styes, but anybody who gets one sty is more likely to get another, and then another, and then another. Just finished treating my 90-year-old father for a sty. Some people get them more than others.
Okay.
I don't think it's any related to the aniridia itself.
Okay. Let's say your child is complaining that their eye hurts. So you're not seeing any pink or anything like that. At what point do you call the doctor?
My kid had aniridia. I would call them when they complain. Now, keep in mind that kids around the age of 2 and 3 and 4 often complain of this or that or whatever. My granddaughter seems to always, the other day she had a thing, she wanted a wheelchair. I mean, they come up with these things, right?
Right.
And I think that you listen to your child. If your child is continuing to complain of pain without you asking spontaneously, if you're concerned, see your eye doctor.
Yeah, that makes sense. What other symptoms would prompt a call to the doctor between visits? Like what would you want to get a phone call about?
A red eye, any eye that has made a significant change in its appearance, say clouding of the eye in a baby, for example, or the pupils beginning to look white, any tearing or pain that's developed and is persistent. I gotta be honest with you, at least in my practice, I encourage my parents to call me for anything. If you're concerned, then you should call your eye doctor. We work for you. That's my job. I'm your servant. So feel free to call.
Awesome. Now, somebody asked, okay, my baby's eye just got scratched. Now, we talked about, obviously, she needs to call the doctor based on what we've said. Is it like, do I need to go immediately someplace, emergency type thing? Rinse with saline? Is there anything else I should do? Or can I wait till the next day, call the doctor?
If your baby's had an eye trauma and it's a red and there's a scratch, you need to see eye doctor. You don't have to run into the emergency room. You don't have to go that night, but by the next day you should be seen. There's very few true ophthalmic emergencies we have to run to the eye, except there's an obvious trauma or there's a bigger change in the appearance of the eye. Most things can wait till the morning.
Okay. Julie from California mentioned, my child's ophthalmologist gives me very little information. How do I get her to be more communicative?
Yeah, I just want to go back to my last answer. If your kid has a tube in the eye,
okay,
and you've noticed a change, say it looks like there's something wrong with the graft over the tube looks funny to you, that can be an emergency. Can be a same-day visit. Because the tube can come out of the eye or get infected. That's important. You want a community doctor. I mean, there's not a lot of eye doctors out there, but there's enough that you can interview around and find the right person. You may have to travel a little bit to see your doctor. Having a child with a rare disease like aniridia, and I'm a rare disease doctor, that's all I see. Sometimes you got to travel to see someone who will talk to you and treat you the way you want. You have the right to have the care you want. And if you're not getting it from the doctor you're getting it from, you got to look elsewhere.
Absolutely. Yeah, somebody in the chat, actually, Kelly asked, how exactly do I find a doctor like Dr. Levin?
Oh, there's a lot of great doctors. Dr. Netlin was on, he's still on. He's a great
he's
doctor. There's so many people around the country who know the disease and are familiar with the disease and who give that kind of excellent care. I'll help you find someone. there are people out there, and you can find them. Not every doctor is the doctor for you. I may not be the doctor for you, right? Can't be friends with everybody. But you got to advocate for your child and make sure you're in the hands of someone who's answering your questions and makes you feel comfortable.
Excellent.
That's my point of view.
Absolutely. All right, so here's a question that often comes up. Should dilation drops be used on aniridia eyes? For like,
Okay, so
refract.
the answer is yes and no. You don't, if a patient has true aniridia or even some remnant of iris, you don't need to dilate the pupils. That's one form of, so when you get your dilating drops, you're actually getting two kinds usually. One just dilates the pupil. The other relaxes the muscle inside, the focusing muscle inside the eye. Those drops are absolutely necessary if you still have a lens in your eye, you haven't had cataract surgery, for us to measure your glasses, so on and so forth. The other reason you may use those drops is after surgery. They keep the eye from being in pain. They also change the position of structures in the eye, which can be useful for some kinds of glaucoma surgery, for example, and can prevent scar tissue. So there are situations where those drops, the ones that are the muscle relaxing kind of drop in the eye, are indicated, but rarely do we need the pure pupil dilation drops because the pupil's already dilated.
Right, that makes sense. Now, are these drops, the ones that relax that you would actually use, are they preservative free? And if not, does that matter?
They're not, I believe there are preservative frees. I've never used them because one drop installation like you do in the eye doctor's office, that's harmless. Preservatives aren't going to do anything bad. But I think that some patients are on those drops chronically, say after surgery. They may be on atropine, for example, for a while. I don't even know if there's a preservative-free form of it. I've never used it. I think it's fairly benign. You're never on them for a long time with aniridia.
Okay. Can dilation drops contribute to high pressures?
Rarely.
Okay.
In some forms of glaucoma, they can aggravate the situation. But in aniridia, that's usually not much of a problem.
Okay. And is there a difference in the dose of a dilation drop? Somebody asked that once, between an adult dose and like a pediatric dose.
Yeah, kids need stronger drops because the muscle inside the eye is much more robust. That's why I'm wearing these bifocals, because as you get less young, the strength of that focusing muscle gets to be weaker. So we often need stronger drops to relax that muscle inside the eye.
Oh, that's interesting. Okay.
And your age also. So infants, we tend to use a lower strength drop than the normal childhood drop because it can be absorbed into the body. So all those considerations come into play.
Okay, excellent. Can you give us, Sarah from Illinois asked, can you give general guidance on the use of screens for kids with aniridia? Like, is it a problem or bad for their eyes if they want to sit really close to the TV or close to their screen?
I've got really bad news for everybody. Sorry to say this. It's harmless. If your kid could get close enough to be inside the television, they would, right?
Mm-hmm.
It's really harmless. I don't believe there's enough evidence to tell us that it's bad at all.
Okay. Do blue light glasses have any extra benefits for kids with aniridia? Do they have benefits at all? What are your thoughts on that?
I think phony.
Okay.
I wouldn't do anything. I would say, there's a lot of talk now about kids getting outdoor activity,
right,
to decrease the incidence of nearsightedness. None of that work was done in kids with aniridia, and I'm not sure it has any applicability. There's no evidence that blue light really does much at all, and certainly nothing about having aniridia that would make it any different.
Okay, excellent. All right, so let's talk about a little bit about amblyopia, or a lazy eye. How do you know if a child has that, and can you describe it, I guess, a little bit for us first?
There's two kinds of lazy eye. Some people use the term lazy eye for an eye that drifts out of alignment. either to one side or in towards the nose or up or down. That's a form of strabismus or eye muscle misalignment. The other form of lazy eye that you're talking about is when the vision development in one eye is slowed because the brain isn't paying attention to it. So anything that makes one eye preferred over the other will cause the brain to prefer the better eye. Something as simple as having one eye more nearsighted than the other, or more farsighted in particular than the other, will cause the brain to use the easier eye to see from.
Sure.
And then it doesn't pay attention to the weaker eye and the vision doesn't develop as well. That's what amblyopia is. It is the most common problem in pediatric ophthalmology. 2 to 4% of all children have it. We fix it by patching the good eye
Okay.
to force the brain to use the bad eye, to kind of exercise the vision more and pay more attention to that eye. So it's something we're always on the lookout for amblyopia in kids. Every time you go to the eye doctor, your eye doctor is looking for it. I'm certain of that. There's no way that you can really well tell unless an eye is drifting out of position. It may drift out of position because it's not seeing well, because it's amblyopic. And if you ever saw eyes drifting out of position, that'd be another reason, not urgently, but to call your eye doctor and get an appointment.
That makes sense. If patching is necessary, how long should a patch be worn, or does it depend on the child or the age?
So first of all, we don't patch with a contact lens on.
Okay.
And there are some risks to patching, scratching the eye. So you want to make sure you're doing it right and under supervision. You never do that on your own. The amount of patching is based on the age of the child in part. We used to patch children all day long, 24 hours a day. Over time, we've come to learn that part-time patching, as little as 1 or 2 hours a day, can be effective, but it takes longer to work. There's different ways to patch different kids, what they'll tolerate. Sometimes it's easier to patch a kid longer. Sometimes it's easier to patch a kid 15 minutes every hour. There's different ways to do it. So it's based on the depth of the problem, the age of the child, right? And the behavior of the child. Those 3 things work together to come up with the final formula of what your doctor recommends. And even then, different doctors may recommend different times.
Sure, that makes sense. Does patching help the nystagmus at all? David from Tennessee wanted to know.
Yeah, if a kid has nystagmus, right, their eyes are shaking back and forth, and you cover one eye, the nystagmus in the other eye will often get worse. That's called latent nystagmus. But one of my mentors showed many years ago that if you leave that patch on long enough, especially after a couple of days or so, it'll go back to its baseline. It certainly doesn't make the long-term prognosis for nystagmus any worse, but immediately it may increase the nystagmus, which is pretty harmless because it'll go away.
Okay. So speaking of strabismus, we get a lot of questions about strabismus surgery. How do you know when a child actually needs a strabismus surgery instead of just patching?
So they're 2 different things. Patching is for vision. Strabismus is for straightening. We try to avoid strabismus surgery until the vision is equal between the 2 eyes.
Okay.
So the normal kind of usual routine is you patch, and when the vision's equal between the 2 eyes, then you do strabismus surgery. Because it helps if after strabismus surgery to keep the eyes aligned if they're both seeing the same.
Sure.
Whereas if one's weak, it's going to continue not to get much attention or drift back out of position. A number 2 thing is the age of the child. The younger the child, the more impact you have on vision development, and therefore a little bit more urgency. Number 3, the amount of crossing. Some kids are born with really, really crossed eyes, right? We're not going to let that go as long. We're going to want to repair that sooner. So all of those things come into play when we're making that decision. And lastly is if a kid has a tube or has had glaucoma surgery, there may be some additional risk or even cornea disease in actually doing the surgery that may cause a physician to say, let's let the eye turn. It's not so bad. It's more important not to mess up the glaucoma operation.
Okay, multiple factors there, certainly. Is a strabismus surgery, we know that aniridic eyes, you need to be very conservative with surgery, right? Is a strabismus surgery as likely to have complications in an aniridic eye as some of the other surgeries like glaucoma or cataract or whatever?
Yeah, so let's qualify your statement.
Fair enough.
Aniridia, there's, in the hands of a decent surgeon, aniridia doesn't really present any additional problems. You have to be more careful not to scratch the cornea, for example. But if we put all that aside, strabismus is the least risky surgery because you're operating on the outside of the eye, not inside the eye. When you're inside the eye with aniridia, there's no iris to protect the lens behind it. So we have to, can the risk get higher that you could hit the lens and cause a cataract? We position a tube in the eye differently than we might in a patient without aniridia. But other than those really specific factors, there's not much difference in aniridia and others, especially with eye muscle surgery.
Okay. Okay. When it comes to eye muscle surgery, based on what you just said, it sounds like, that's not just cosmetic so that it looks nice that the eyes face the same way. It actually helps with the brain development and the vision development. Is that correct?
Yeah. So the word cosmetic surgery is when you don't like your nose or other body parts that are normal, and you have an operation to create a new normal. That's cosmetic surgery. Strabismus surgery is not cosmetic, it is reconstructive, where you're taking an abnormal appearance and normalizing it. So kid whose eyes are turned out, if you make them straight, you're normalizing the appearance, which has many, many advantages for the kid. It's not cosmetic. Not only does it perhaps help the kid looking out of the eyes, for example, decrease the chance of amblyopia because you can't look at both eyes at the same time if they're not pointed in the same direction.
Mhm.
If they're both pointing in the same direction, there's less of a chance that one eye is going to get lazy in its vision. But in addition, it helps people looking in at the child.
Right.
And there's been studies that show that a kid who's got an eye that's misaligned, teachers automatically assume that they're dumber. And you got enough challenges. So there's an advantage to your appearance as well in that case, which is a functional change, not a cosmetic change.
Absolutely. Absolutely. All right. Let's see. We have a number of other ones still. Let's see. You mentioned that in babies, you do cataracts if they have them, they're newborns, between 4 and 6 weeks. How do you know in a child when cataracts need to be removed?
Yeah, that's particularly important in aniridia because a cataract simply means there's a darkness or an opacity in the lens of your eye. And the lens can have an opacity anywhere in it. You can have a cataract that's not in the center of your vision, that's off to the side, doesn't affect your vision at all. You don't have to do anything. So we only do surgery when either one, it's blurring the vision,
Okay.
or is at risk to blur the vision. Two, I can't see in what I need to see, right? So if kid's got glaucoma and I need to monitor it or see something inside the eye, then it might need to come out. And the third doesn't really apply to aniridia. That's when the lens gets swollen. That's really not a factor here.
Okay.
So we can look in the eye with our instruments and we can see how well we can see in. That's a reflection of how well the kid can see out. We can measure the vision. If the vision's getting worse from cataract, those are the things that really help us determine whether cataract surgery is needed. The other thing to keep in mind is if the retina is poorly developed, you're only going to be able to get the vision so good. So taking out a small cataract is less impactful. And in fact, the risks have to be weighed against the benefits. There are risks to cataract surgery more so than in children who don't have aniridia. So you have to balance all these factors to make the right decision at the right time.
Okay. Speaking of which, let's say my kid, the ophthalmologist is recommending the cataract surgery, and many ophthalmologists do cataract surgery. Can any eye doctor do cataract surgery on a patient with aniridia, or should they find somebody who's done it on a lot of people with aniridia?
Yeah, I think if you drive a Honda, you probably take it to someone who fixes Hondas, right? But there's a lot of people who fix Hondas. If you drive a Lamborghini, you're not going to take it to your Honda dealer, right? So if you consider all of your children and all of yourselves who are affected as being Lamborghinis, you want to take them to someone who knows what they're doing, who's used to this. And adult surgeons do 20, 30. I've seen a cataract surgeon do 100 cataracts a day. Is he skilled? Sure. Is he skilled in aniridia? Probably not. There are pediatric cataract surgeons. It's perfectly fine to ask your cataract surgeon, how many kids have you done with cataract? Do you do a year? Now, if they say I do 3 a year, that's not a lot. You want someone who's doing many more cataracts a year in kids. And do they do kids with aniridia? You have the right to ask that question and get a response that's satisfactory. And if it's something that doesn't sound so convincing, find someone who can do it and do it well. There are some tricks and some special, kids aren't just little adults. If that were true, there wouldn't be children's hospitals, and there wouldn't be pediatricians, there wouldn't be pediatric ophthalmologists. We specialize in kids. You wouldn't want me to take out your adult cataract because I don't do that. So you want to go to someone who knows what they're doing.
Okay, that makes sense. Chris in the chat just said, Dr. Levin, are you taking new patients?
The answer is yes. But I think, you just need to find the right fit for you, and that person should know the disease.
Yeah, absolutely. Another question, what is, and I never say this right, but ptosis? I never say.
Yeah, ptosis, the P is silent.
That's what I thought.
Ptosis is a droopy eyelid.
Okay, and is it something that can be treated, that should be treated? Do we see it more in aniridia than in other children?
So ptosis is associated with aniridia, even more so with Wager syndrome. The repair of ptosis in aniridia is really no different than the surgery in any other child who's got ptosis. The big difference is when you do ptosis surgery, you can raise it a little too high or limit the ability for the eye to blink and close. And of course, being able to blink and close protects the surface of your eye and keeps it lubricated, so that you really need to be careful when doing ptosis surgery for the right reasons. Ptosis is usually not going to impair vision.
Okay.
Usually, if you're young and it's more severe and in one eye, it can. So you want to do the surgery at the right time in the right kid.
Okay. We talked about exams under anesthesia a little bit with Dr. Netland, and we had him on. But we've noticed that different doctors kind of have different philosophies on this. And so we're wondering, how do you handle them? Do you do them routinely, despite a child who's cooperative? Do you do it only when there's a concern? Do you do a baseline? What are your thoughts?
Well, I like to do a baseline when a kid first presents. The reason for that is because I can get information while they're asleep that can be useful later on. A picture of the optic nerve, a measurement of the length of the eye, but it's not absolutely necessary. What is necessary is, if you are looking to find your spouse or your child, right? Well, your child's not likely in Afghanistan right now. You can rule that down. You feel pretty comfortable your kid is not in Afghanistan. You can feel pretty good that your kid is not in some other state, right? So you don't look there. So if you need to find him, you're going to look where you know he is, and you're going to do everything you can to find it. So if you're concerned about a child enough that you need a piece of information to help you make a decision, whether it be the eye pressure, the length of the eye, or better look in a screaming child, you do anesthesia. There have been many studies done. Trying to be short-winded, not long-winded, I'll just say that I believe the literature now shows that the risk of general anesthesia and multiple anesthetics is minuscule, if at all.
Okay.
And the need for the anesthetic, the reason it's being done is far greater. I'll just tell you one little anecdote. Every professional society, including American Academy of Pediatrics, came out with a statement that said, if your child, you should avoid anesthesia of more than 3 hours in length. Now think about that. If you need an operation that's going to take more than 3 hours, you need the operation,
Right.
right? Whatever it is, that means it's serious. So
Right.
you get the operation. So you do what you have to do. And I use them freely. I use them when I need them. I don't overuse them. I don't use them when I don't need them. It's a very important tool in the management of many children, especially kids with Wager syndrome who have other additional challenges and are harder to examine, right? So I think you use them when you need them.
That makes sense. I
And
had
by the way,
oh, go ahead.
every single parent in the world worries that my kid is going to die or have brain damage under anesthesia. Every single parent. It has been well shown that the chance of your kid dying or getting brain damage in your car driving to the doctor's office is higher than the 15, 20 minutes of anesthesia they're going to get. So you got to put it in perspective.
Yeah, that's very helpful. So out of curiosity, and we'll probably talk about this more in a future episode with some corneal experts. But Chris from South Carolina wanted to know, are you aware of any kinds of new research to help anorectics like replace their own stem cells or help with their cornea? What can you tell us since we have a few minutes?
The most, I think, exciting research is the research around delivery of some method to help stem cell development around the eye, or what we call limbal stem cells, either through a contact lens or eye drop, or maybe even topical gene therapy. That's got a lot of promise, and I think we're going to see that in the not too distant future. More challenging is gene therapy that's been suggested to redevelop the retina. I think that is, we haven't had the results of the Adaloran trial, so we don't know, but I think that's going to be disappointing. But ultimately, the way gene therapy is going, I think that's a possibility. And I think that, that's a possibility in the future. Those are the two things that are big news. Cataract surgery, there's been developments in implants and things like that, which really don't change the outcome very much. Glaucoma surgery, there's been a lot of developments in different kinds of glaucoma surgery, but that's not specific to aniridia.
Okay.
There's an interesting question here. Joy writes, never had an EUA, but after surgeries later one, did have other issues after going under. Not a fan as an aniridic. And that is absolutely fine. I want to answer that because some people don't need them. I have patients who've done fine and they're great. But you know what patient I really am sad about? The patients who didn't have it, who got missed.
Yeah.
The glaucoma was missed because once you got it, you can't go back. So, and problems after anesthesia, what does that mean? Some people have problems, they wake up, they're upset. Some people wake up, they're nauseous. There's ways, the next time you go in, you tell the anesthesiologist the ways to circumvent those problems.
Yeah.
You got to do the right thing.
Yeah. And I would imagine very different for an adult who, who's being treated as opposed to a child too, harder to get accurate exams on a child, I would think.
And there's another question here about, I'm sorry, but I just can't help notice.
No,
Are goniotomies still used? Absolutely. It's my favorite operation. Goniotomy is still used. It may not always be appropriate. It's not the right surgery for every kind of glaucoma, but it is a great operation. It's very quick, very easy. Literally takes me about 2 minutes to do, low risk. So we use that in many instances. There's other forms of skinning the cat in different ways, but we still do that.
Okay. Excellent. A couple of people asked about the artificial iris, and I didn't know if that's something you know a lot about or want to talk about. Okay. Mohammed from Egypt asked, is it safe, and when in the child's age should that be done, in your opinion?
So the artificial iris, I believe, is really a bit of a misnomer and a bit overhyped. Number one, you don't need an iris. Your iris is not necessary. Too much light and all that, it really doesn't bother. If kids with aniridia are having problems, or patients with bright light bothering them and surface irritation, that's from the surface of the eye, something that putting an artificial iron isn't going to fix. They're still going to have the cornea problems that are making them feel that way. Number two, it's a big operation. And any operation in a person who's predisposed to glaucoma or already has glaucoma is only going to increase the risk of aggravating or inciting glaucoma. It really becomes truly a cosmetic operation. Reconstructive, no, you can't see my pupils. If you look at my dark brown eyes, you can't see my pupils. So I have a woman in my practice who went 40 years in her life and never knew she had aniridia.
No kidding.
Because she was mildly expressing. She had vision of 20/40, no glaucoma, and she just she had dark eyes.
Sure.
So it's really not an operation that I feel is indicated, except for cosmetic reasons. That's my personal opinion. Let's ask Dr. Netlin how he feels on that. What do you think, Peter?
Let me see if he weighs in. I don't know if he's still here because I haven't looked, but
He's still here.
okay.
No say.
Yeah, I totally agree with that. I think it's a challenge because there's also the aniridia fibrosis syndrome.
Yeah, I didn't mention the anamorphic fibrosis syndrome. That is a very, very rare but very devastating condition. And it's always in the back of my mind every time I go inside a child's eye with aniridia. That you basically do well-meaning surgery and the eye just shrivels up and dies. It's a very rare, terrible, frightening.
And I guess my point was going to be that it can be a profibrotic syndrome, aniridia. So if you're throwing in the artificial iris, it's in an area where, it can have a risk of that or other risks. And the gain is sometimes not so dramatic. I just saw a patient yesterday, actually, who had a pseudophakic in one eye. And it looks exactly like he had an artificial iris put in, but it was just a natural lens capsule that was there that had become a little bit opaque and looked just like an artificial iris. So I think, you have to, every person is different. In some situations, I wouldn't say that I would disagree. It's easier to put in at the time of the surgery because you can put it in the capsular bag. I'm certified to do them, but I don't do them really often at all in aniridia, more traumatic cases of traumatic aniridia. But I because of the risks, I'm just concerned about those. But I do think I'm basically agreeing with you, Dr. Levin. I feel like it's maybe not something that would commonly be needed.
Yeah.
I'll stop there. Sorry.
No, that's great. And Sarah here from Ontario, I believe is where she's from. Is there any concern with a child being on glaucoma meds long-term rather than having a surgery? And it looks like her child's on a number of different ones twice a day, wondering if there's a risk of longer-term med use or whether surgery could be a lower risk.
So 60% of kids, no matter what the operation is, 60% of kids still need, on average, drops after surgery to help that surgery work. Usually less in number than before the surgery. Fortunately, we're very fortunate that almost all of our eye drops in kids really have very, very favorable risk profile, very low risk. The prostaglandins like latanoprost and travoprost, they can make your eyelashes longer. That's not going to hurt you. In fact, maybe even cosmetically pleasing. There is really little risk, except for the long-term effect of preservatives and drops may, in a minority of kids, be a problem. Acetazolamide, oral Diamox, I use it very freely in my practice. We've studied it, the incidence of having problems from that long-term through childhood, maybe worse in kids tolerate it much better than adults do. I'm happy to use that. And I have found in my practice that 99% of parents, if given the choice of taking an extra drop or having an operation, are going to pick the drop. And I am not afraid of medicines at all, especially in aniridia.
Okay, that's super helpful. Would you believe that we had something like 70 questions before we started here, plus questions in the chat, and you have answered every single one of them. That is impressive to have gotten through that in less than an hour. So I just want to say thank you again, Dr. Levin. This was really helpful. Some of the best explanations that I've heard ever of some of those things, which is great to have this resource for parents going forward. So
My pleasure, and
so wonderful.
anyone can feel free to get my email from the foundation. You can I'll just say it. It's Alex_Levin, Levin at URMC. That's University of Rochester Medical Center, urmc.rochester.edu. Feel free to ask questions or pass them on to the foundation.
Thank you. And before we leave, I would love it if everybody, I'll change the security things here to let everybody start their
Wait,
video.
hold on.
Oh, go ahead.
The email that's in the chat is incorrect. There's no E on the end of my name. It's Alex_Levin without an E. That E is too expensive to rent, so we don't use it.
Awesome. Thank you very much. All right, let's go ahead and have everybody turn on their cameras. And I will stop the focus mode and turn off the spotlight here so that we can see everybody, hopefully. If it lets me turn off my spotlight, there we go. And we would love then to just see everybody, see everybody's faces, and get some screenshots here if at all possible. Let's see if it works.
Hi, everyone. Hi, Rosalind. I got your email, so I appreciate your question.
Let's see who else turns on cameras. See what we can get.
I always love the group photo at the end.
I do too. It's always fun. So fun to see all of my friends here. Justin, Rosalind, Jamie, Chris, Sarah, Joy, Cassidy. Rosalind, I think Sarah is from Ontario, right, Sarah? Do I have the right person?
My fellow Canadians, hello.
Rosalind is also from Canada, so. All right, I'll grab a couple more shots here if I can. It's always just fun to see everybody's faces, so. All right, I think we are all set. Let me make sure that there's nothing else I was supposed to tell everybody before we turn it off. I think that's it. If you have any feedback about tonight's episode.
Look at our little one here.
Oh, hello. Hi, sweetheart. She's so
Those
precious.
curls.
Oh my goodness. I love the curls. If you have any feedback, please feel free to let us know. We have an email address, focalpoint@aniridiana.org, and I'll post that here in just a minute as we're getting ready to leave. So please always let us know what your thoughts are. Thank you for joining us. We're going to leave the meeting active for a minute in case anybody wants to do any more chat, through the chat function. And then we'll just look forward to seeing you all at the next episode of Focal Point. We like to, remember that together, or alone we're rare, but together we're a whole lot stronger. So thank you again, Dr. Levin. And we will see you all next time.
Thank you. Pleasure to be in a room with a bunch of Lamborghinis.
I love that, and I'm so going to use that from now on. That my
Take
daughter-
care.
Now on.
Take care and be well. Thank you very much.
Thank you, Dr. Levin.
Thank you,
night.
Dr. Levin.
My pleasure.
Thanks, everybody.